Working with these larger groups that oftentimes have influence with the legislature is where you actually make the most movement. You can talk to your legislator about it, but you as an independent constituent are likely not going to have an impact on policy change. It's going to take the masses. Working with those agencies is really beneficial, and I would say even more so at the federal level, because the federal government's just so huge, and even these agencies are huge, that finding the right connections within them really helps you to navigate through, who to get to and how to make a change. It's those relationships that you can call on when you want to make a change. And so I've always just had this mindset of always trying to be as diplomatic as I can. And, if there's something that you're really passionate about, that it's worth fighting for.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 263. My name is Andrew.
And my name is Michelle. Welcome back to the podcast.
Welcome back, everybody.
Okay, I want to start this off because I'm a little agitated.
Yes, I love when we start off the podcast with your complaints. And everyone else does too. People love it.
Where Michelle goes on a rant. I don't know if they all love it, but here it is anyway. I've taken all of my social media off of my phone because 2020. I do, though, log on every now and again and answer messages or just check, make sure I don't have 47 notifications that I'm missing. I do have 500 friend requests, and I'm sorry, y'all, I'm just going to miss it. If you friend requested me and I haven't said yes.
Look, everybody, I'm so popular. People love me and I don't have time for you. Oh, I'm such a pretty princess.
No, I think people just see person that you want to know. Click. I'm like, girl, I don't know you. Boy, I don't know who you are. I listen to enough Crime Junkie podcasts to know I don't need you to know where I am all the time.
Wow. That's a good way of looking at that. That seems healthy and normal.
Well, listen to just a minimum of 5 Crime Junkie podcasts.
No, I'm not going to, because I don't want to get into that rabbit hole of...
Listen, it's not negativity. These are real life things. You got to be your own advocate, y'all. That is what I have learned. Be your own advocate. Anywho, back to my agitation. So I log on, and the first thing on my news feed is, I don't even know what group this was in, but somebody was asking, and I did do a live the other day on Level Up Infection Control. That's my other company and Facebook and Instagram thing with India Chance, because this was an infection control post. And they were asking, do you wear nitrile gloves? And I'm assuming they mean the utility gloves, because we have nitrile exam gloves, but we also have nitrile utility gloves. And I won't even get into the specifics of it. I think we all know OSHA and CDC specifically says that we should be wearing these things during instrument reprocessing, operatory reprocessing. But what I was just struggling with, this group has probably 10,000 plus people in there, and everyone is literally incriminating themselves, saying, nope, don't do it. Don't wear it. Those are silly. Those are bulky. I haven't done that since hygiene school. And I'm just going to say, listen, it's probably not going to happen every day. It's probably not going to even happen every week or every month. But there are certain situations where if you were to have an infection control breach, or something happens to you, you get stuck, and then you have to go through the process of getting HIV, Hep B tested, all those things. And then you try to file a workman's comp claim and your doctor wants to fight that. Where do you think they're going first? Social media. And then they're going to be like, oh, Andrew, this you, boo? This you over here saying I don't wear nitrile gloves. They're silly. I haven't done it since hygiene school. And they're going to be like, oh, that's adorable that you wanted this workman's comp claim for something that you could have prevented and you chose not to do it. So I'm just going to say, we're all adults. We can all make our own decisions. You should be wearing them. If you choose not to, just know it's probably not the smartest thing to go put that on social media with 10 to 20,000 people to review it.
For sure. And so my little rebuttal, or it's not even a rebuttal. I asked if that was to you earlier. I was like, well, do you think that people are really going to do it? Go
probably not.
Hunt you down and look through all your social media and you're like, yeah, for sure. There's lawyers. That's what they get paid to do, is to fight these things. So here's my thought though about this. I've listened to Teresa Duncan enough times now on her podcasts,
which is a great podcast. Chew on This.
Nobody told me that, and Chew on This with Kevin Henry. Both of them are amazing. And she talks a lot about like office management and just everything there. She's so incredibly smart. And she talks a lot about the employer now. So if you are friends with your employer, like I know that we've all worked in these situations where maybe we didn't really love the place that we worked, but if you love the place that you work and they don't have these protocols already in place, where I understand that the CDC and OSHA has said these things, but if you don't have written documentation into your practice, help them get that. There needs to be a protocol in place. It is a law that they have in place. And if they don't have that in place, you need to help them and protect them. And if you are an office manager listening to this or a doctor listening to this, make sure that those procedures and protocols are already
standard operating procedures. They're super important. And if you do get an audit, they will ask you, where are your standard operating procedures, especially for your sterilization center. And, to ask you, since you're in this hiring role, I was in a hiring role previously. I don't know if you do this, but I definitely went and searched all the groups I'm in for that person submitting a resume.
I don't want to give away all my secrets in case someone does apply later on.
I will say that I did and will do in the future.
I have done though. So I have looked them up on social media on the occasion. Sometimes it's just to figure out how to say their name though too. Because on Facebook, it has like the pronunciation guide.
Yeah.
So I'll do that, or I will see if they are part of groups. I don't really do like a lot of investigative work on them because through the interview process, I can kind of get a good feeling. I mean, it's 30 to 45, sometimes an hour long interviews, some of these ones. So it's not even an interview. It's more of a discussion, clinician to clinician kind of discussion. I want to know what their protocols are. I want to know what they understand. I want to know all these different things too. So yeah, sometimes I do a deeper dive, but not usually.
Yeah. Well, that's just me being like, I want to know who I'm about to hire. I'm also directly working with them if
it was a smaller office, I'd definitely be a little bit more picky about who it is. But then you also usually know that person because they're in your community with you and all these other things as well.
So true. But all of that to say, like, y'all don't put things on social media in groups. Like, this is not private. And I don't even want to know, like, when there's a bitter person who is, well, I shouldn't say bitter because I screenshot like nobody's business, but people going to screenshot and then they're going to send it in somewhere.
Yeah.
So just keep that in mind. And Lord knows I've been posting a lot of things on social media people don't love, but I stand behind those things. So don't even come with me with those comments either, because we all put things on social media. It's more of like, are you willing to stand behind them? So I know that you had a great interview with Matt Crespin.
Number 2 interview without Michelle. Oh my gosh.
Which, I mean, I'm also very jealous, like, because these are my friends and I'm like, oh, I want to hang out. I just want to say one thing about Matt. There are so many people that have disappointed me in 2020. There's so many. I could go on and on. But there are some that have truly made me laugh. And Matt Crespin is one of them. And I want to say thank you to Matt for being a funny dude and making me giggle in some moments when I'm like, the hell is the world coming to?
It was nice having the ability to chat with him because I feel like there's different sides of Matt, right? He has so many roles and so many things that he has to do. And his experience has made him actually like really well-rounded, incredibly smart. I had the goal going into this because next month, February, is National Children's Dental Health Month.
Nice. Yep, you're right. February. Mm-hmm.
I was like, hey, I'm going to do this thing. That was the mindset. I had all these questions for this. As we started talking, it ended up changing into something completely different, which is, typical Matt because he has so much knowledge. It ended up being
typical
more like conversation. Yeah, typical us too. I was like, well, let's this tangent. We're going to go down. And then we really went down it. Here's the premise. It's legislation, which sounds like a dry topic, but if you are tired, like just sick and tired of things being the same, and that same is not good, and you want change, like meaningful, like for realsies change, he's going to help you figure it out. He has some really good ideas in this episode. So take some notes, listen to it a lot, share it with your friends. It's a really great episode. Matt's amazing. And here's the interview with Matt Crespin. Before we get to the interview, we want to say a big thank you to Paradise Dental Technologies, or PDT, for supporting the continuing education portion of this podcast for so many years. If you do not know already, many of our full-length episodes count for CE. You'll find the links in the show notes, or you can sign up for our newsletter by going to ataleoftwohygienists.com. When you sign up for the newsletter, we will periodically send out links to shows that have expiring CE courses attached. And none of this could be possible without the support of the amazing people over at PDT. So check out their hygiene and other instruments at pdtdental.com. That's pdtdental.com. Now, on to the interview. Welcome, everyone, to the interview portion of this here podcast. I am joined today by none other than Matt Crespin. You know what I want to introduce you as, though, Matt? Not immediate past president ADHA Matt Crespin, podcaster, official podcast host of the ADHA podcast, Matt Crespin. How does that feel? I
appreciate that. It feels good. Actually, I just updated on my Twitter handle, on my description, I put podcaster because I saw somebody else do that. And I thought, well, I do that now, so I'm putting that on there.
By the way, you're doing a great job hosting that. I really enjoy the interviews.
Thanks.
I'm obviously a little bit far behind, but I was listening to the one with Jennifer Frame because she's, from Washington, and I love that. And it's harder than it looks, though, isn't it? Being a host.
It is. It takes a lot more time than I thought it would, just to try to find the right guests and to find the right stories. And then sometimes people are really nervous, and I'm like, there's nothing to be nervous about. It's like you and me having a phone conversation that somebody else gets to eavesdrop on.
Exactly. Well, and the way I like to look at it is these are just conversations. There are definite CE course type things that come out there. But the one thing I love about your guys' podcast, it is highlighting the individual hygienists that are doing amazing things and tying it back to, well, how can someone else do that? I feel like it's almost like a roadmap for someone else to replicate and know what kind of educational requirements they need to do, or what path, or who the connections are. And I'm sure all of them would love to be contacted to share their stories.
Yeah, it's been kind of fun too. I've gotten several messages from listeners that have said, oh, I listened to so-and-so's podcast and something they said really stuck with me. And so then I've been able to actually connect those people together that didn't know each other, for them to talk about, what they're passionate about. So it's been kind of fun. I really enjoyed it. And now that my year as president is over, I feel like I have a lot more time to actually do it. So it's fun. It's fun.
I think that what you just said, though, really does kind of embody almost one of the main tenets of what ADHA is supposed to be about, right? It is networking, connecting, building up each other. It's just a network. It's a wonderful opportunity to help each other out. And I love that. So how has it been? I mean, you were the president during this. Hold on. I wrote down exactly the term that I was going to use. I can't find it. But I mean, the essence of it was that you were the president during the most impactful pandemic I think that has ever hit, at least certainly our generation, if not, multiple generations. You stepped up, you did your thing, and now you get to step back a little bit. And how does that feel now that you can do that?
You definitely take a step back and you feel like you have a chance to breathe. I mean, those from March to June when I got done, from the time the pandemic started, it was just nonstop. And I feel fortunate that my employer was very understanding that I was focusing heavily on ADHA stuff because everything that was going on. But it feels good. And Lisa, that's now stepped in, is doing a great job. And hopefully the next president doesn't have to continue to deal with it. Hopefully we're getting close to having it a little bit more managed now with the vaccines coming out. But yeah, it was interesting. There was never a dull moment. And I guess I feel excited that I could be a part of that, but it was crazy times. Still is, but it's good now.
Do you think that people, when they see you on social media and things like that, do they still look at you as, this is Matt from ADHA, or do you think that are starting to transition you back into, this is Matt, the colleague?
Yeah, you're always going to have that hat on as a past president. I mean, all of our past presidents, I always view them as ambassadors to the organization. But I've actually really enjoyed, now that I'm done, being able to dive back into my work, reconnecting with our staff teams. And there's a lot of transitions going on within our organization, and lots of exciting things happening even in the midst of COVID. But it's been fun to get back to that stuff. I enjoy it a ton.
It's funny because the reason why I asked that question is when I see you, of course, you're my friend, and then that's what I see you as also, football and, fantasy football, all of those things aside, just all the sports stuff that we've been able to do together. I still think, so next month is National Children's Dental Health Month. And so I still think of, when I think kids, I'm like, Matt's got programs. Matt's doing these things at a level that I haven't really seen a lot of my other colleagues doing. Not that they're not doing it. It's just that, that's my interaction with you. And so it's funny that that's how my view is of you.
Yeah. I mean, I think you'll always sort of wear both hats. And I think people see you in the light of probably when they met you. And so, I knew you, I think probably even before I came on the board, maybe right when I started on the board. But I think that's maybe what it is people that I met during my year as president will always sort of remember me in that way. And I remember the same way about other past presidents. When I met them as president, that's just what I think of them as, even though they probably have a full-time job.
Well, what I want to talk about today, and the reason why you're here, we have a couple of topics that I'm gonna definitely need your help. It's funny because I'm always coming to you for help. Matt, how do we get from here to here? I always feel like I'm asking you things. But what we're trying to achieve in this episode is I want to talk about some of those school-based programs that are for children. I want to talk about how to get involved, like how do you even do that? But I also want to talk a lot about legislation, and I want to talk about legislation from all of the angles that it is important that you're aware of, because I feel like, having had a firsthand view of legislation for not just what you do for your day job, but also with ADHA, and knowing, of course, what the ADA is doing and all of that, legislation is a integral component to what our profession is. And I don't think that we pay enough attention to that. So, I mean, first, maybe let's talk more about the school-based programs they do. So what kind of programs are you aware of, and how does that get started?
When you think about legislation, the reason that school-based programming can occur in many cases is because legislation has passed in certain states. So currently there's about 42 states across the country that have what, is considered direct access, where hygienists can directly access patients. And in a lot of those instances, it involves hygienists being able to work in schools without the supervision of a dentist. So in my case in Wisconsin, dental hygienists can work in a school setting without the supervision of a dentist. And so our organization, Children's Health Alliance, partners with the Department of Health Services to basically be the fiscal agent and program manager for a very large statewide school-based sealant program. So the state provides funding in the amount of about $750,000. And Delta Dental of Wisconsin matches that funding up to $500,000. So we manage that pot of money. And then we in turn contract with local public health departments, independent dental hygienists, federally qualified health centers, a variety of different groups to actually go out with portable equipment into schools and provide that care. And it wouldn't be possible to do that. In some states, it's not possible to do that because there's not been legislation passed that allows a dental hygienist to work in that capacity. The other legislative change that's really important when that occurs is the ability to bill Medicaid, because many of the kids that are seen in our program, roughly 70 to 80% of them are enrolled in Medicaid. And so if you can't bill for the services you provide, then there's no way to sustain the program. So I think the total is 18 or 19 states now where dental hygienists can directly bill Medicaid. So in our case, as a hygienist, you could basically start your own business. It could be a for-profit or nonprofit group that partners with schools and purchases portable equipment and goes out into schools and starts providing care and bills Medicaid for the vast majority of your services. We don't allow our programs to bill patients. So if they're not enrolled in Medicaid, the services are basically covered. That's what our funding covers. And right now, there's not really a mechanism for hygienists to bill private insurance, but we are starting to work on that through another project that we're involved in. But, at the heart of it, it's legislation. It's the policy at, the legislative level. So whether it's at your state assembly and Senate that changes the law, or changing rules, which is typically what your state dental board would have purview over. And sometimes it's a combination of both. I find it easier. I shouldn't say easier. I find it more effective to work at the legislative level than at the rules level.
Is that not a longer process, though?
It can be a longer process. Sometimes it can be a much shorter process, and it's I chuckle when I say this, but it's sometimes less political. And what I mean by that is you don't typically have the politicking between organized dentistry and organized dental hygiene or public health organizations or oral health coalitions. The legislators can kind of understand how these things work, and they can pass a bill and put it in place. And sometimes when it goes to the dental boards, their role is to protect the public. And sometimes the protection of the public gets put secondary to business protectionism, essentially. And that can get dicey. And most dental boards are predominantly dentists. In our states, there's 6 dentists and 3 dental hygienists. In some states, there's only 1 hygienist in some cases on their dental board. So you're typically outnumbered.
So is that okay? So let me go back to actual the day-to-day nuts and bolts of it. So I'm a hygienist. I've created my own business, and then I'm going to be contracted for services rendered. How is the vetting process? Do I have to have anything special for me as far as like an NPI number or something like that to be able to bill?
So in our state, you would become a Medicaid provider. And in order to do that, you'd first get an NPI number, and then you would apply to the state Medicaid office for a Wisconsin Medicaid number, and then you would be able to bill directly. There's a few counties in our state where Medicaid doesn't directly contract for payments, but they work through a managed care organization. So you would then have to, in those counties, contract with the managed care organizations. Our group has developed a really good relationship with the managed care group. So typically when a hygienist comes to managed care and says, we want to provide school-based services, typically the first question they ask them is, are you involved in the Seal a Smile program, sort of the overarching umbrella that we administer? And when the answer is yes, there's typically not as many hoops for them to jump through, because they know that in order to be one of our programs, they have to follow a specific set of protocols. We do site visits. We have specific requirements in place, and as far as what kind of sealant material you are required to use, and using four-handed dentistry and a variety of different things, just using evidence that it helps ease some of the hesitation on their end from contracting with those groups. So then the program, if you're a hygienist, you decide you get an MPI number, you become a Medicaid payer or provider, you could apply to us for funding to become one of our programs. And in some cases, we would purchase you portable equipment, pretty much all of your supplies and stuff that you need to get going. And then we reimburse you for the services that you provide. In fact, we just changed the way we're reimbursing programs. We used to just say, if your budget was $50,000 and you assumed that you were going to recoup $30,000 in Medicaid revenue, our grant would be $20,000. So we'd basically fill the gap. What we've done now is we've realized that we can get better outcomes if we pay based on services rendered. So we pay based on the number of kids that get screenings, sealants, that get at least 2 varnish applications. And then we have an incentive payment that goes at the end of the year that's based on participation. So if they increase their participation as a program or as a school, they're going to get like almost a multiplier times everything that they provide. So there's some incentive for them to get into schools and encourage teachers to get kids enrolled in the program. So this is the first year we're doing that. So the programs were pretty excited about it. And then COVID hit. So, it'll be a little bit different this year. This is definitely a challenging year because only about 20% of our programs are operating. And even at that, they're operating at very low levels. So it's a way for them to, generate revenue through Medicaid, and then we help cover some of the other costs. Some of them will do other grants and fundraising opportunities, but usually us and Medicaid are the 2 big funders of our programs in our state.
Do you feel that, because you're able to be a part of this, the dental part of it, that things are getting run really well? Or do you feel like, so before you, who had this role? Was it also a dental hygienist? It's always been dentally driven?
Yeah, there was so in February, I'll have been with Children's Health Lines for 15 years. And prior to me, there was another hygienist there. And the program started about 20 years ago. And it started because a group of partners from around the state got together and said, we want to have an impact in oral health, and we think that school-based care might be the best way to do it. And so they advocated to the governor at the time to invest funding in the program, and the governor invested $60,000. And from $60,000, we now have $1.2 million and 40 programs that provide care in about almost 1,100 schools across the state.
Is there obviously some of the metrics that you're recording are, varnish applications and sealant applications and screenings and things like that. But what other metrics are there outcomes based metrics that you're looking at as well?
Yeah, we actually probably 5 or 6 years ago, we, in partnership with Marshfield Clinic and Delta Dental, developed an online data collection tool. So it's almost like a electronic dental record for all of the kids that we see in our program. And we're able to now track kids over time, whereas before we weren't able to do that. So we can see when we place a sealant, we can see 2, 3, 4, 5 years down the road, has that sealant been retained? We can also see, did kids develop decay? Or, are we reducing decay in the number of kids that we've put sealants on? So we're able to pull quite a bit out of there. In fact, we're also able to pull a lot of cost data out of there. So, what is the cost per child to seal each kid that we see or each tooth that we seal? We're able to work with programs that might report higher cost per child to help figure out ways to kind of bring that cost down. Maybe it's just changing the way their workflow is for the day.
So I feel like your guys' program, I feel like your state, I've always loved Wisconsin. Always. It's really well ran. It's really well understood. There's a lot of buy-in with the leadership, both with dentistry and also outside of dentistry. When we were there before, like you had some really good partners with legislators and things like that. So is that typical for most states?
It depends on the state. I mean, there are some states that are really good at, there's many states that have state oral health coalitions. We are one of them. And I think the advantage to working in a coalition is you can bring together groups of people that have a similar goal, but you might not, on the flip side, think of having them be at the table as being important. And, for example, in our state, we have groups like AARP and disability rights groups and the Wisconsin Hospital Association, very influential groups, both from a policy side, but also, they have a vested interest. The Hospital Association is vested in good oral health access because they don't want patients coming to the emergency room for dental care because costs them money. It's a loss leader. So they want people to find care in the most appropriate way, which is not in a hospital emergency room. So you can get a lot of buy-in from them. And we actually have worked quite well with our medical colleagues. So the Wisconsin AAP, the American Academy of Pediatrics, family physicians, the medical society, especially the Hospital Association, in a variety of different legislative actions that we've moved forward. One was the opening up of practice settings for dental hygienists to now practice in more than just schools. So in Wisconsin, dental hygienists can now practice virtually everywhere for the most part, except in a dental office without the supervision of a dentist. So in our state, it's actually more restrictive as a hygienist to work in a dental office than it is pretty much everywhere else, which sounds kind of odd, but it's what legislative change happens. It's what happens when you make legislative changes. And the reason that we did that primarily was we wanted dental hygienists to have the ability to work in medical offices. And the hospital that I work for, we have about 30 different primary care locations around the state. And the doctors were saying, well, why can't we employ a dental hygienist to see some of these patients when they come in for well-child checks? And we said, well, it's a great idea, but the law won't allow it. And when you tell a physician that they can't supervise somebody, they kind of lose their mind a little bit. So it was easy to get them on board. And, we were able to get that law changed back in 2017. And then we applied for funding to actually implement a program where we're now trying to integrate dental hygienists into medical settings. So, the way that looks is a hygienist gets employed by a health system or a federally qualified health center, and they don't really need a lot of equipment. Many of the hygienists that we work with, their equipment is like a shower caddy that has, a mirror, toothbrush, some fluoride varnish, some stickers, and they follow the physician around the medical office all day. So physician sees, Susie that's here for her 2-year-old well-child check. Hygienist looks in the mouth, does an exam, talks to mom or dad or grandma, grandpa, applies fluoride varnish, maybe applies SDF if they see something that is concerning, and then refers them to dental, maybe internally or maybe externally. What we found was that there were almost 100,000 kids that were ages 0 to 5 and enrolled in Medicaid that were visiting a physician and not visiting a dentist.
Wow.
So it's just a huge opportunity to reach kids that are already coming in the door. You don't have to pay a physician to do this. You can pay a hygienist to do it. It's much more efficient, and you can bill for more services. You can bill for an exam. You can bill for SDF if you did it, varnish. They could bill for varnish before, but what we found is not many providers were even doing that. They don't have the time. They just have so many other things that they're working on.
You know, I'd be interested to see like the demographics behind that. I was speaking with one of our colleagues before, and there is, and not to step over her work too much, but she has this, 3 years old is the average age for a Caucasian child to see the dentist. And then I believe it's 12 and then 16, 3, 12, 16, I believe, for a African-American child and a Hispanic child. And I would love to see are they able to go see their physicians more often and then also get the dental care that way so we can bring that disparity down a little bit?
Yeah, the hope with this program is that when we went to change this law, one of the biggest pieces of data that we used was the percentage of kids in Head Start that have dental disease. So in Head Start, you're already talking about a low-income population, and it's a variety of different race and ethnicities. But what we were seeing was that by the time kids were 3 years old, already 30% of them had experienced decay. And by the time they were 5, 50% had. So getting them in Head Start isn't early enough. And if kids aren't getting to the dentist till they're 3, it's already too late. So if you can get them at 6 months, 9 months, 12 months, 18 months, 24 months, 30 months, 36 months, you're getting like 7 to 8 dental encounters before the kid is 4 or 5 years old. And so then when they're handing them off to dental, they're already healthier. They're in a much better shape than they are coming in when they're 8, 9, 10 or 5, 6, 7 and have to go to the operating room for a general anesthesia case because their whole mouth is rampant decay.
I want to go back to the legislation piece a little bit. So I'm a hygienist working in my state. I am looking to see how I can get involved in legislation change. What are some of the best avenues? You mentioned the coalition before, but what else? How do we get this how do I be a part of this?
So I think the two best points of contact are your state dental hygiene association and your state oral health coalition. Almost every state has a state oral health coalition. And I would say in the past 5 to 10 years, state oral health coalitions have gotten much more active. There's now a national organization called the American Network of Oral Health Coalitions. And there's another group that is kind of a spin-off from a project that the DentaQuest Foundation funded for several years called Open. And their website is easily accessible. And a lot of the state oral health coalitions are very actively involved in these two national groups. So there's a lot of information sharing back and forth. There's a lot of, I'm on several different listservs where people will ask questions about, how did you go about adding adult Medicaid benefits to your state's Medicaid offerings? Or how did you go about allowing dental hygienists to work in different settings? So I think if you're a hygienist, getting engaged with those groups is important. But I think the other thing that's important is that legislative change or policy change can be really overwhelming to somebody to think about. It's like, how do you even start? You call your own legislator. Does that get anywhere? But I think working with these larger groups that oftentimes have influence with the legislature is where you actually make the most movement. You can talk to your legislator about it, but you as an independent constituent are likely not going to have an impact on policy change. It's going to take the masses. They need to hear from the elderly adults that live in their district. They need to hear from the physicians that live in their district, the dentists. That's where they really, you see movement. So I think getting engaged with them is helpful. And I think the thing that I've learned and tried to impart on people is your legislators do want to hear from you. And sometimes 5, 6 phone calls to a legislator's office from 5 different constituents is enough to get the ball rolling, because then they start going, well, now I just heard this from somebody else that dental hygienists can't work in a medical clinic. Well, that doesn't make sense to me. And now somebody else just called me about that from a health system that I represent. Now a dentist called me and said they'd like this to happen. So those coalitions oftentimes are so broad-based in who's at the table that, you might have a physician, a dentist, a nurse, a teacher, business owner all at the table, and they all come at this for a different reason, but they all have influence on their elected officials in that way. So one group, typically it's hard for them to change legislation. Even a dental hygiene association can, by themselves, they don't yield as much power as you would think they would. They really are successful when they've brought broad partnerships together. And that's true at the national level too. ADHA has been successful because of some of their big partnerships with other organizations to move the needle, whether it be on, dental therapy or, a variety of different things. It's typically not one group that's making those changes. It's a broad coalition.
So I think it's very interesting that you bring that up, because I'd love to kind of transition into the national level of legislative change. I was listening to a podcast just the other day, and they were talking about the ADA, and the ADA, who most of us have just like a really bad taste in our mouth because, oh my gosh, it's the dentist, right? They were talking about these really amazing changes that have gone through with reimbursement. A simple little silly thing about changing the law for reimbursements for certain states and kind of like just unlocking something for so many providers, so many patients to have the access now. I would love to know, kind of like at the ADHA level and maybe ADA level, whatever you feel comfortable discussing, one, some of those partnerships, but two, some of those types of things that are really changing things for the everyday, either hygienist or for the patients to get the care that they need.
Yeah, I would say there's a variety of different ways. One story that I can tell you, this kind of goes back to during the time when I was the tail end of my presidency, and these relationships that any organization builds, whether it's ADHA or state group or Children's Health Alliance, they take years to cultivate. It's not something that you just flip a switch and all of a sudden you have the in. An example that I could share with you is during the pandemic, one of the times when CDC put out guidance for dental settings, and I off the top of my head, I cannot even remember what the actual example was, but I remember reading through the guidance. And at the time, we started to get deluged with emails from our COVID email box with all these questions about this specific piece of information that was in the guidance. So I reached out to Ann Bottrell and I said, I think we got to figure this out. We got to find out what this means. Because of the relationship that ADHA has cultivated with CDC over many, many years, she's able to make a phone call and get a call back from the dental administrator from CDC by the end of the day. So, that's a relationship that any hygienist probably wouldn't be able to do, and most groups wouldn't be able to do, to be able to call and get a clear answer and in turn get them to then update the guidance and clarify what they were saying so that it eliminated some of the confusion. So, that's an example of, that was an ability for then hygienists to be able to practice in the most safe way during the pandemic. It impacts patients to make sure patients are protected and the rest of the dental staff. That's probably one example. We're doing a lot of work with a big group of partners on dental coverage in Medicare, because there's very limited dental benefits in Medicare. And there's a big movement to try to integrate oral health services and reimbursement in Medicare. And so that's a federal change that has to happen.
So is that group kind of like a coalition, but at a federal level that we're sitting at the table of and having discussions and influence with?
Yeah, so you're at the table with other national groups, AARP, groups like that represent older adults or disability rights groups, and medical people too are at the table. So the coalition work, whether it happens at the local level, and I've been involved a lot, we manage a Milwaukee Oral Health Coalition. We've had impact, on things like community water fluoridation and access to care locally, all the way up to the federal level. My thought is the more people you can have at the table with more voices from different perspectives, you just get a whole lot more done. I think the weight your message has is so much heavier than one group.
Do you feel though sometimes as you're sitting at this table, right, and you have all this knowledge, all this background, and you're like, you guys, this is such an easy decision to make. Put this slot right here and it's going to be so successful. And then you pitch it and everyone's like, I don't get it. I don't understand. Does that happen? Does it take a while to get something done?
It does. If it's a legislative change, it takes finding the right legislator that's going to care about it. sometimes you can have the greatest idea, and until you get a legislator that goes, well, that makes sense to me because the district I'm in, it will be impacted by this. So getting them to buy in is one thing, but then getting them to understand it. These are legislators that are making decisions on healthcare and infrastructure and roads and everything under the sun. And so they can't become experts. So you have to be able to explain it to them in a really easy to understand way. Otherwise, it oftentimes does go nowhere or it gets pushed off to the side. But luckily, we've been successful in finding great champions at the legislative level. And even at the federal level, we've had great partnerships with legislators to, kind of help move the way that dental hygienists practice. And I would say at the federal level, it's sometimes legislative. So it sometimes involves elected officials, but oftentimes it's more federal agencies. So like CDC and Health and Human Services. We've developed a great relationship with the Surgeon General's office over the past couple of years. And so those types of relationships really help navigate the legislative piece because they do the work at the federal level and they know how to navigate it within these huge agencies that exist.
Because I was just thinking, I'm glad you brought that up, though, is about the agencies and being able to work with them, because I know if I was to repeat this information to someone else, if you want change, you do X, Y, and Z. I just talked to my buddy Matt. He told me all about it. And they're going to come back and say, look, I'm not a politician. I can't do the politicking to get these things changed. I just want to help. So it sounds like there's more than just legislators, but you could work with maybe agencies and cultivating relationships there.
Yeah. I mean, oftentimes those relationships in my case, we work a lot with the State Department of Health. A lot of times we'll have conversations with them and they'll say, it would be great if we could do X, Y, Z. As a state agency, they can't advocate for that. They can do some of the behind the scenes work, but then we might be able to say, well, we would be able to kind of push this forward from a policy standpoint. But in order to do that, we need a little bit more data. So then they can pull the data for us. And then we have that information. So there's ways to work together with groups like that to get the information that's going to be beneficial for both groups. And then each group is able to sort of do what they're able to do within the bounds of, I guess, the legal bounds of what they're able to do. State agencies can't testify at a public hearing unless a legislator on the public hearing requests them to be there. But as an organization like I work for, we can come to the table to any public hearing and provide testimony. So working with those agencies is it's really beneficial. And I would say even more so at the federal level, because the federal government's just so huge. And even these agencies are huge, that finding the right connections within them really helps you to navigate through, who to get to and how to make a change.
Do you think there's any value in, going back to the variety of individuals that exist in this world that don't want to do either one of those two options, working with those groups? Is there any value, do you feel like, working with, a parent-teacher association or something that's a lot smaller level, even this doesn't exist, but like Dads for Fluoride, like some sort of a group like that?
Yeah. I mean, I think everybody finds value in engaging in policy change in a different way. So whether it's at the local level or state or federal level, it can be different. And, what I would say is one really great way to get engaged is to attend some legislative day for maybe your state hygiene association or maybe your oral health coalition. My employer is a hospital, so we actually go to the hospital association's advocacy day. And usually the day consists of the morning, there'll be several speakers, and they'll then kind of help you understand how to talk to a legislator. And then the afternoon part of the day, you actually go and visit your legislator. And people view it as a bit of an intimidating process because you're in this big Capitol building and, it's old and it just has this nostalgia to it. And you walk into the office and there's this, sort of formality of meeting your state senator or your state assembly person. But at the heart of it, they are people that they're your neighbors. I mean, they live right around the corner from you. In fact, in my old assembly district that I used to live in, my assembly person lived right around the corner, and I'd see him when we'd walk around the neighborhood, and they're just, they live and work in your community, and they want to hear what you have to say because they're not experts in everything, and they know you're an expert in dental care. So sometimes going to, or even just calling a legislator without any ask whatsoever and just introducing yourself and saying, I'm a constituent, I'm a dental hygienist, I work at such and such location, this is what I do. If you ever have any need for input on dental issues, give me a call. So it's a no pressure introduction. And now you're a resource to them versus having to go to them when you want something. So developing the relationship on the front end, I think, is huge. And it's not super intimidating once you do it once or twice.
Matt, you, my friend, are one of the most unflinching, positive people in the face of adversity that I've ever come across. You have, in your time with ADHA, and I'm sure with your job, run into a ton of no's, or I can't stand you, or why are you doing what you're doing? How do you maintain that level of, engagement, positivity for, change for the better?
I mean, I think, especially when it comes to policy change, you never know what legislator, you never know what organization might be your next ally. So I think cultivating relationships is really important for me. It's something that my boss has imparted on me for the past 15 years. And it's those relationships that you can call on when you want to make a change. And so I've always just had this mindset of always trying to be as diplomatic as I can. And, if there's something that you're really passionate about, that it's worth fighting for. And, finding the people that are willing to partner with you to do that, I think, is important. And I think it's the relationships that you build over time that allow you to be successful in that. So I guess it's just like it's embedded in my DNA, I guess.
I love it. I have one last scenario. I want you to walk me through how we can make this happen, and also for our audience, obviously, how they can make it happen in their state. So I have a vision where, because of infection control has been a big thing, top of mind for the last COVID for sure. But even before that, I would like there to be a position at the state level outside of dentistry, but at the state level, who goes into the offices and checks for compliance. And I understand that supposedly that already happens, right? That doesn't really happen, especially with COVID being the way it is. So how do we create that program? How does it get funded? I know you're like, oh my gosh, why'd you ask me this question without even prepping me? And how do we get individuals, or how do we get people to apply for that position?
I think a position like that, I would venture to guess that it does exist in some states. I probably not in all states, but it sounds like what you're kind of describing is almost like a food inspector that goes to restaurants and checks for compliance, but in the dental world. I'd venture to guess that it exists in some states, but I know in our state, those visits don't occur just at random. They happen, after there's been a complaint filed or something like that. And then they call and say, hey, I'm coming on Thursday. So, the office has the opportunity to sort of clean their act up a little bit, but
sign all those logs that they're supposed to be signing and doing all that. Exactly. And that's the problem, in my opinion, having worked in, maybe 100 offices in my tenure. I know that this is a problem.
Yeah. And I mean, you and I both see the stuff that people share on social media. And so we know it's a problem, that there's just some, there's bad eggs in every batch. And so, yeah, unfortunately, the way that most states operate is that it would have to be a state level change. So a state would have to, and maybe the way that it works is a state does it, and then they sort of share model legislation with other states to then get it passed. And it might even be at the dental board level, where it's a public safety issue. You raise the concern of, here's the number of complaints that have been filed against dental offices in the past however many years. We really need to look closer into this, and you have a public hearing and you get somebody on board. But it would end up having to be a state by state change. But I think it would be a great position. In fact, I don't know if you know Robin Kuster. She's a dental hygienist that works at our State Department of Health, and her and I work really closely together. She's like my infection control go-to. When I have a question, I go to her, and her and I talk about this very thing. And it's like her dream job. It's like what she would love to do, to come into offices and do that. But yeah, it's certainly a public health issue, right? I mean, we don't want patients to be put at risk, and what better way to do that than to have some sort of compliance and regulatory way of monitoring that, at least.
Yeah, I think it would be a great job. I think there's so many of us that would love it. Business owners might not love it at first, but I think if they are doing everything they're supposed to be doing, then there's nothing to hide, right? So I think that's a great opportunity for for someone to workshop, brainstorm, and figure that out for us. And then also come back on the show and then let us know how that goes. And that'd be awesome. Matt, thank you so much for your time. I'm sure people are going to want to reach out to you. What is the best way for them to reach out?
The best way to reach out is they can email me, and the best email address is through my work, and it's mcrespin, CRESPIN, @chw.org.
Fantastic. And also don't forget to check out the ADHA podcast, which he does a great job hosting. All right, Matt, thank you so very much.
Yeah, thank you.
Well, another great week, another great episode. We thank you all so much for listening each week. If you haven't already, hit that subscribe button, whatever podcasting app you're using. Also, just a reminder, our guests are so fantastic that they love when you reach out. They love when you interact with them on social media. And you can interact with us on social media as well at Instagram or Facebook. We're also on LinkedIn. You can find us at A Tale of Two Hygienists. You can also go to our website at taleoftwohygienists.com. And we would love for you to go there and subscribe for our newsletter. We have lots of stuff on our website. We have a learning center. You can search for any episode. This is an easy place for you to find the links for our CE courses and take the test. There's just so much more there. So head over to ataleoftwohygienists.com. And if you want, you can also send us an email. I'm Michelle at ataleoftwohygienists.com. And then there's Andrew, who is Andrew at ataleoftwohygienists.com. And we just want to say thank you so much. If you love this episode and you're loving the podcast, we would love for you to subscribe and leave us a review. And, 5-star, go ahead and do it. 5-star, just hit that 5-star and then leave us a review. We really appreciate it. We love reading them. It fuels our fire. And we just appreciate you guys so much. I think that's it, Andrew. Anything else?
Nope, that's it. Have a good week, everybody.
Bye, y'all.